Okay. Dr. V predicts that this is going to be the most popular episode of Truth or Trend for Ozempic and GLP-1s we're going to talk about today. We've talked about these a lot, but the twist here today, if you're listening, is what can you do to help keep that person who is going to do it, no matter what, from experiencing the worst of all of the side effects that are happening? What can we do? Because we know people are going to do it. And what can we do to keep them from turning into a statistic and having all the other damages, all the stories? We've had a lot of people that have come in. We did our darndest to help them understand the dangers and understand why this is something that we would never do and why we would do everything else. And there are so many other things we can do. But there's such a juggernaut of people out there saying, oh, it's a miracle, it's this, it's that, it's the other thing. We just have accepted the fact that we're going to have to just clean up what happens. So, back by popular demand, we have our first repeat guest ever, Dr. Jeff. Ladies and gentlemen, thanks for being here.
Maybe I took it wrong, but I thought I was the reason it was going to be the most popular episode, Dr. V. So
it's all about you.
Thank you. Yeah, I think that often, but I don't think it's true. But anyway,
bring it.
Appreciate it.
That's the perfect storm. I'm going to start with a story and then I'm going to pop it off to you guys. As soon as Dr. V said to me last week, we need to talk about this, I got a text from a client of mine. He's in his 70s, fit guy. He's actually a competitive weightlifter, right? He's going for a record in power lift at his age, and he just can't seem to lose a little bit of weight. And so he reached out and said, hey, my son-in-law started taking tirzepatide, and, that's been all the difference. So what do you think? Should I do this? And he also has some other medical conditions that would definitely be contraindicated. All I did was say, look, here's why I wouldn't, and he's been saved. But so many people are saying that this is the Hail Mary, the panacea, the golden bullet, the whatever you want to call it. So what do we do if we can't bring wisdom to them to try to do the natural things? And they're going to jump into this, and a lot of people are. Now, people have gotten some great weight loss. Okay, I don't want to take away from the victories that people have had. But what can we do now to make sure that they can live to enjoy those victories in the best possible way?
Well, and I mean, that really exposes how brainwashed and how profound the marketing is really behind this. When a strength athlete, that's his whole goal in life is to be strong and have muscle mass, and one of the most primary side effects is muscle loss. And yet this guy's willing to compromise his being, if you will, to get rid of a little bit of muffin top, with a cheater pill or cheater shot, right?
Yeah, a lot of sound bites, muffin tops and cheater pills. That's going to be the title of this episode. I'm going to, there's another story, actually, real quick. I was out in your neck of the woods, Dr. V, and this lady came to me. She's a yoga instructor, and she has this huge, following in Malibu and all these women, but they're all losing their butts, literally, right? And that's what she said to me. She goes, these women are working out, but they're all losing their butts. And I said, it's because they're just not eating enough. They're not getting enough protein, because this is shutting down that sense, and you can't build muscle. And this is why people, as you said, they lose twice as much muscle as fat when this is happening. And I just want to remind everybody of that. So from a practitioner standpoint, I'd love to hear where you guys go with this, but I throw protofood into the protocol immediately for these individuals, always, because I want to make sure they're at least getting all the essential amino acids to stand a chance to do all the repair that their body's trying to do. What do you guys do for that piece right there?
Well, I mean, my first recommendation to everybody is make sure you're getting 20 to 30 grams of protein with every meal, half their weight in grams of protein, at least, because they need to do, bare minimum to maintain that muscle mass. And we're going to talk about helping the stomach function so that they can make use of that protein that they do eat. But I think early in the podcast, I want to get Dr. Crippen's perspective on, the mechanism of action and how this stuff works, so we can set a foundation, a baseline. Okay.
Yeah. Yes. So let's do that. And because I think that kind of drives a lot of the decision making. Like, the better we understand how these drugs work, the better we can do it. So what are we talking about? We're talking about GLP-1 receptor agonists. We're talking about Mounjaro. We're talking about Wegovy. We're talking about Ozempic. And so the mechanism of action, so there's kind of four main mechanism actions. The first one, it's an anoretic drug. Anoretic, kind of like anorexis, meaning you don't eat. right? So it's just shutting down appetite. So we just generally in caloric restriction, that's the problem, but that's also the benefit of these drugs, right? Or what you're going for. So the second thing is it's an incretin, which means it stimulates a decrease in blood glucose by increasing insulin production. So that's why it's also used for diabetes. So we're talking about raising insulin, dropping down blood sugar. So that's 2. 3, it inhibits the release of glucagon for the pancreas, so which slows down raising blood sugar. So inhibits release of glucagon, also has a net effect of lowering blood sugar, and it reduces gastric emptying. This is the gastroparesis that we're seeing 3 to 4x risk of that happening. So basically, just slowly, it slows the whole digestive tract, shuts it down, and it's artificially lowering blood sugar. And just as a reminder, GLP-1s they're naturally made by our body. And when they're made by the body, they have a half-life of between 90 seconds and 5 minutes. So it's something that's naturally there. When we take the injection, or possibly the pills that they're investigating now and possibly going to roll out, you're taking something with a half-life of 7 days. So instead of that lasting for 90 seconds to 5 minutes, which is a slowing of digestion, which you might want at the end of a meal and kind of that contributes to the feeling of satiety, you're now getting that for weeks to months to years at a time, cumulatively, but certainly weeks to months, because at the end of 4 weeks, there's still, half 75, there's still, 5% of what you took a month ago still in the body. So anyway, so that's what's happening. So as we do that, we need to be aware of what can we do to maximize digestion, because the drug is literally designed to slow down and inhibit digestion. And like you said, twice as much twice as much weight loss as muscle compared to fat. The 2 of the biggest studies are saying 39 to 40% of total muscle loss total weight loss, is muscle. So absolutely quality protein, and then protein digestion, I think have to be big things. So, talking about protofood, essential amino acids is awesome. And then I think an evaluation of hydrochloric acid production, what can you do to maximize that, and proteolytic enzymes. And then zinc's going to be involved in that production as well. So an evaluation of those 3 areas, I think, is also going to be complementary to it. And you need to do, one or both with the patient, depending on their individual presentation.
And that's why I mentioned the protofood, and like you said, the supporting the digestion, that's obviously the top shelf, what we should be doing. But as you just mentioned, the signaling, they're not thinking about eating anymore, right? So to tell them to eat 40 grams a day is one thing, but their brain's telling them not to, right? So you have to figure out a way to be able to reinforce that and also still keep them from wasting away, which they're going to, even if they're told they need to be getting that protein. Because I think a lot of people are aware that we need protein. Again, like you said, not digesting it, but what else can we do? Because it is going to be inevitable if they're not going to eat that protein, that they're going to waste away like that.
A couple of things along those lines Dr. Crippen, fantastic summary of what's going on. And you did kind of put it in lay terms to some degree for the non-doctor that's listening. GLP stands for gut lymphoid protein. Basically, this is the gut and the pancreas, the mental joy of food, all kind of being affected. Along those lines, leptin is the kind of the emotional component to carbohydrates, right? To insulin, it basically parallels insulin. And leptin, when they inject rats with leptin, they'll basically overindulge themselves to the point of death. They basically gorge to death, because when leptin goes up, when we eat a big meal, it says, I'm satisfied, I'm happy, I'm good. If that's not, so basically they're keeping that up so the person is satiated, as you mentioned, for a week, for a week straight, instead of just being, fat and full on the couch for, 20 minutes after a meal. So that, part of that's going on. And then think of the conundrum, which is pretty typical with big pharma or with pharmaceutical stuff, is they're shutting down protein metabolism. Gastroparesis means less stomach acid, more poorly functioning stomach, which is we need to break those proteins down into amino acids to get use of them. And so we're shutting that down, setting the stage for loss of muscle, which is most of our metabolism, right? Muscle is what stokes the fire for us to burn calories through the day. And so, I look back at, we've been around this for decades, where typical calorie restrictive type diets that, Weight Watchers and all that sort of garbage back in the day was restricting calories. 50% of what they lose is muscle. Then they oh, I lost my weight, and they go back on the binge eating and they gain back 100% of that, as fat instead of 50% of the muscle that they lost too, so they lose, say, 50 pounds and 25 of its muscle, then they gain back 50 pounds and it's 50 pounds of fat. And so it
Yeah.
slows the metabolism. I mean, I grew up around this
Yeah.
crazy yo-yo dieting that just, repeatedly slows metabolism down further and further over the years. So that's really kind of what, my vision for this podcast was to, minimize that sort of consequences. People, I mean, I've had patients doing really well on it. And, with a few basic supplements, we can really help them through that season and help
Right.
minimize damage control. What do you have, Dr. Jeff?
Yeah, no, I think that's great because I think that fits. One of the things I came across is, how much fat can someone possibly lose in a week, right? And what they did is they looked at college athletes. They put them on a caloric restriction diet and had them working out somewhere between 6 and 14 hours a week. And they basically said you're maxing out losing 1 to 2 pounds of fat per week, right? With
Okay.
caloric restriction, with maximizing protein, which kind of makes sense because, I mean, I don't know about you guys, but I've always heard healthy weight loss is a pound or two a week. So it's kind of
Yeah.
cool to find something right behind it that kind of says that's what it is. And so it means if we're losing more than that, we know, it's muscle to a greater or lesser degree, maybe a little water rate the first week or some things at the beginning. But after we handle some inflammation, we're losing muscle. And I think you hit on the key point was you can lose 50 pounds, then gain it back. But if half of it's muscle on the first time you lose it, then you don't gain half the muscle back. You're at the same weight or even 5 or 10 pounds down from where you started, but you're less metabolically healthy. Right. And that manifests as a slower metabolism, like you said. So there's, obviously there's more to it than just the number on the scale. But certainly that protein issue, I think, is a real big important first step for anyone taking these medications to make sure you're understanding that.
A key metric, I mean, as you brought up, kind of in the current market, fortunately, a lot of the scales now, the
Yeah.
bioimpedance type scales actually measure muscle mass and body fat. So, I
Yep.
mean, that's an easy, probably less than $100 scale that's going
Yeah.
to tell
Yeah.
your total. I mean,
Yep.
it's not 100% accurate, but it's pretty accurate, especially on the body fat part, because this impedance measures fat slow, accelerates
Yeah.
conduction. And so, I mean, it's an easy thing to measure when if you are one of the people that is going to go this route, use a scale like that measures your total muscle mass, your body fat percentage, that measures water, those things, bone mass, easy things to keep track of without having to do a lab test per se.
Yeah.
Dustin.
Well, so let's shift into some of the things that you guys are saying that you are seeing people get good results, but what are some of the things that we have to layer on to inhibit the maximum damage that's coming from these? And the first thing I'm thinking about, as you mentioned, and I think it's worth repeating, Dr. Crippen, that the native life of that, if we make this endogenously, is 5 minutes maximum, right? Versus a week long. And so the analogy that I try to share with people that I'm talking about, it's like, okay, there's somebody calls you once a week. Dr. V calls me once a week and asks me questions, and I can handle that. That's great, right? And once a week is a good cadence, and I can handle doing this once a week. But if he every day, all day for a week and said, we need to, talk more about everything all the time, then I'm going to get wore out, right? And
You stop taking my calls, kind of like insulin receptors, right?
exactly. I'm going to stop answering. And that's what's happening to the hypothalamus, right? The hypothalamus is being visited by something that it would be getting, like you said, for 2 to 5 minutes. It's being deluged with it. It's drowning in it. And so the hypothalamus is going to need some support, correction, and protection in this, right? And this is where I oftentimes have the hypothalamus PMG for that reason, and often hypothalamex as well while they're on it, and then for at least 6 weeks after they finish. For me, that's the way that I've been working with individuals who are trying to cut back, do it less and less and less, keep the gains that they have without having their whole endocrine system completely crushed.
Mm-hmm.
What do you guys say about that?
Go ahead, Dr. Jeff.
Yeah, I mean, I think that makes a ton of sense. That's one of the questions that I'm sitting there with is, this question of could continuous activation of the GLP-1 receptor via those drug agonists lead to receptor downregulation, making the drug less effective over time, right? Which is basically a fancy way of saying, is your body going to start ignoring Dr. V's calls if they keep coming in too much, right? And that's a question, and that's something I think that's really important to look at. So I think that makes a lot of sense as a nutritionist, as a practitioner, to consider that when we're looking how to support the patient. And I think the other thing is, Hippocrates said it, 2,500 years ago or so, all disease begins in the gut. But I think we really got to think about digestion because we know digestion's compromised. And as we're supporting them with supplements or food interventions, I think we really got to make sure that they are digesting it because we know that's being downregulated. So obviously just starting from that digestive standpoint, then I think we can build some fun things on there. And obviously just taking it, looking at the hypothalamus for as a target of that receptors makes a ton of sense. And then we just, check and double check that they can digest the food interventions that we're recommending and or the supplements that we're doing as well to make sure that it's going to be as effective as it can.
Mm.
It's insulin sensitivity, right? That, everything we can do to help keep that. I mean, a lot of what I'm doing is pancreatic supplements and so on. Let's call this the second half. So let's just kind of on at the front end outline. We're going to be looking at stomach metabolism. First thing we're going to tell the patient, as Dustin brought out right away, is protein. Make sure you're getting proper protein, right? We want to keep the stomach functioning. Typically, I'm looking at something to facilitate pancreatic function, herbs, we'll talk about some of those. And then fiber is a biggie, gut bacteria stuff. So anything else you want to add to? So the 4 or 5 things that you're bound to look at with anybody that walks in on or wanting to take or on a GLP product?
Yeah, well, I'll tell you something funny about that because what do we need? I think I agree with you. Here's the foods that maximize GLP-1 production: protein, especially animal protein and especially liquid protein and especially protein mixed with calcium. So bone broth would be an example of that. Raw nuts, avocados, olive oil, vegetables, especially fiber-rich vegetables such as Brussels sprouts, carrots, cauliflower, among others. So basically, what are we trying to do diet-wise? Well, interestingly enough, the foods we'd recommend they do are exactly the ones that naturally stimulate the body's own GLP-1 production. So I think those are kind of things you're thinking of. So we got to handle digestion. I think it's interesting to think, do we need to support the adrenals if the blood sugar is being pushed low, right? And, most people may not be eating well enough for that to be an issue, but they could be eating and then just kind of on that roller coaster where it's going high, they're taking the drug, then it's going low, then it's coming back up. So is that putting some extra stress on the adrenal? And then there's a 50% increased risk of kind of gallbladder disorders, biliary dysfunction.
Nausea, right? Everybody talks about nausea with them.
Yeah, exactly. And up to 90% of people have digestive symptoms on it. 30% quit the drugs within the first couple months. But so do we need to do anything to support gallbladder function, especially given all of this, given the gastroparesis, given the biliary dysfunction, and given the fact that we're shutting down digestion and we want to make sure they're still getting nutrient-rich foods, including healthy fats, to make those fat soluble or to digest those fat soluble hormones and get those omega-3s in as well. So those are kind of the big things I'm thinking of there.
It's a perfect point of with most drugs, if diet and exercise doesn't work, so I mean, you just basically described the diet. We would say, hey, try this. And if,
exactly.
God forbid that doesn't work, maybe consider a GLP. I mean, you basically just laid it out. The other aspect, I think that called it the sixth thing that we want to look at. There's been some recent studies that have come out showing that, visual acuity, kind of really some damage in the eyes. So we also want to throw some antioxidants, so some sort of vegetables, but some kind of a good antioxidant type product of, I think a Vitanox works really well for the eyes, or OPC Synergy typically would be one of those two to protect the visual risk with a product like this. So let's kind of unpack some of those aspects. The fiber, we probably should start with the stomach because that's a lot of it, and we've alluded to that. But ginger, right? We're thinking ginger product in the SP lineup for those that are using those, right? Is digest that works whether they're an O blood type or an A blood type. Speaking of, A blood types tend to have lower stomach acid as a category. O's tend to have better, so they maybe that has to do with who's gonna tolerate or handle these better.
Yeah.
But either way, digest is the bomb. Zypan, especially for the A blood types, is going to be, as you talked about, Doc, with the hydrochloric acid plus the enzymes that go in there, that'll
Yeah.
keep, joint aches and keep metabolism up to some degree. Anything else you guys want to talk about on that front?
Yeah, and then maybe even either a multizyme or an Enzacorp or some kind of proteolytic enzyme, and
Mhm.
maybe Enzacorp just works at a little higher pH than the multizyme, but maybe we're looking something for proteolytic enzymes or some digestive enzymes as well in conjunction with or in addition to or instead of Zypan. But I think you laid that out that well, and then maybe a beet type supplement, maybe a
Yeah,
beta food, beta plus, something to support,
definitely.
gut motility and fat digestion.
I would second and third that because of the mental health aspect, that
Yeah.
happens with individuals on this, and the importance of keeping all of that going for not just the use of the fats, but also a clearance of excess of copper. So yeah, I would do a beta food to protect against all of that for the gallbladder issues and the mental health issues. And I want to say on top of this, I'm 100% in agreement with all this, right? From the top down, this digestion at the top. But as I learned from you, Dr. Crippen, when you first presented on this, um, bowel obstructions go up as well, right?
Mm.
4 times. And gastroparesis is going to slow them down. So the question I always have to ask, and this is the question I ask all the time anyway, is that I want to know without a shadow of a doubt that they're having regular bowel movements, right? If that
Mhm.
starts to stop, and we have all this help at the top, then I got to start thinking downstream, right? What is it that's below that we need to bring to the microbiome to help get this all back to running smoothly? Because bowel obstructions are nasty and dangerous, and that's the last thing I want to have happen if I'm anywhere a part of the team that's helping this person.
Let's talk about the mechanism of those that bowel obstruction, right? So basically, it's called the ileal brake. Wally Schmidt was the first one to, enlighten me on this, that, if we don't digest fats well, the valves in the intestine, especially the ileocecal valve and the valve of Houston, they slam shut to give the body more time to assimilate those fats that it so desperately needs, right? So if and the stomach also to some degree will cause those valves to shut down. So if the gallbladder or the stomach are under functioning, then the valves in the intestine, stay shut to try to give the body more time to get those nutrients it, again, so desperately needs. So anything we can do, like we're talking about with, facilitating bile flow and function, keeping the stomach functioning properly is going to, it should eliminate the potential for the gastric blocks that, the spasms that are going on in there. Mm-hmm.
Let's hope. Let's hope. But I also think with the restriction of what they're eating in general, they're going to probably be eating less diversity of fibers. They're not going to be keeping their microbiome as robust and helpful to make sure that
Right.
things are moving there as well. So that, of course, it's the questions we're asking is if they're getting fiber in there in general, and that's going to be another piece that we have to come back to for them, for sure.
Yeah, as Jessica said, just to put some color on what you said about the mental health aspects of it. I mean, what we're talking about is a 45% increased risk of suicidal ideation, right? And
Mhm.
that's a side effect of that again, haven't heard talked about much, but I think it's really important that to bring that up. And
Mhm.
and then that risk rises to a 345% increase if the um if
They're
the
taking an
patient's
SSRI with it, right?
if they're
Right.
also on an SSRI. And
Yeesh.
the EU launched a probe into this, investigating this link. Haven't heard much in the United States about it. And one thing I always want to bring up with this is 95% of all serotonin is made in the gut. So if we have something that's downregulating gut function, right, digestion, that's where 95% of the serotonin is made. So I think that mental health is something that we should think about for everyone, but especially if they're also on an antidepressant, then I think we especially need to make them aware of that, or somebody on their healthcare team, if their doctor didn't already, which I think we can assume that probably didn't happen. So that's a great opportunity for us to step in and just educate them on what's happening, and then, customize a plan to support them through that and with that.
Such a
Absolutely.
great point. B6 is another one of the nutrients that's talked about a lot to minimize the nausea and so on. B6 is a primary nutrient for serotonin metabolism and for GABA metabolism, the two key players that we're talking about here, right? Serotonin, as you just talked about and mentioned, 95% of it's made in the gut. GABA is the brain's control of the gut. When serotonin's low, that's, serotonin's, that's why people are on these SSRI, selective serotonin reuptake inhibitors, to keep that serotonin high, because that's the happy hormone, right? Or happy neurotransmitter. And then GABA is our calmness. GABA needs to go up to shut the brain off to go to sleep. That's our filter. I call it the bad husband thing. That's what we think before we speak. That's where we shut it down to go to sleep. That's calmness. When GABA is low, and we get the shakes, we get anxiety. So both of those are really key players in digestion. And so again, B6 could be a good nutrient to help through that journey. But yes, such a phenomenal point that you just made, that as far as the big consequences potentially. And then I was talking about leptin and insulin. That's all noradrenaline, norepinephrine. That's the focus factor. That's ADD. So when their blood sugar is yo-yo and they get the hypoglycemia, then they can be unfocused and hangry and all that garbage. So yeehaw.
Yeah. Well, and there's so many questions I have on top of that. Well, let's shift into the pancreas aspect of it too, because I remember Dr. Crippen, it always stuck with me when you did your first presentation again. You're talking about gastroparesis being up 4x. You're talking about bowel obstructions 4x, but pancreatitis was 9x when you were talking about that. And that inspired me to make sure that I was bringing in things like pancreatrophin, PMG, right, as a smart tissue support for the pancreas. And when I actually looked into Joseph Antel's protocols on gastroparesis, he actually starts with Paraplex, right, which is a combination of the pancreatrophin, but also the rest of the endocrine support, being the thyroid and the adrenals, which I thought was very interesting, and pituitary. So all of that is going to get dysregulated when we're having these endogenous hormones thrown in there, which is very important. But Dr. V, I think you mentioned Gymnema. You're using a lot of that concurrently with these individuals. Can you talk about what else you're doing, what you guys are doing for the pancreas because of this?
Berberine. Berberine kind of like that. That's all over the social media as the GLP, the natural alternative for GLP. I find it to work really well, and I like berberine because of its effect on the gut biota as well. It helps keep the yeast down, and it helps keep the gut bacteria somewhat in check, so that gut lymphoid protein communication between the mind and the gut and so on. I think berberine works really well. I haven't seen any contraindications, muscle testing or literature wise, as far as using a berberine product or with the GLP. What do you have, Dr. Jeff?
No, go ahead, Dustin. Yeah, no, I
agree
with that.
A good story about muscle testing now that you mentioned
it.
So I was hoping.
So that's probably a good time to bring this in. So somebody had actually known for maybe about a year and a half, never been a patient, called me, horrible back pain, need to get in, this day. So, okay, great. Get them in as soon as possible, adjust them. They get better for a couple of days. Then it kind of gets worse. They come in the next week, gets better for a couple of days, then kind of gets worse. So anyway, we start working through what's underlying this issue, right? No kind of mechanism of injury, just kind of woke up with this back pain. Now I can't walk up and down my stairs kind of thing. So did some work on with using some of the Dr. V's in the Verzal method, AK work. So I got one of those beautiful posters right in my office as well. But started working through. First one that showed up was a weak glute medius, which corresponds to gonad function, ovary or testicle. So we gave some support for that. Ovotrophin, I believe it was, or Ovotrophin P, and got better, but still now we got like 3 days or 4 days out of it, but then it was coming back. So anyway, came back in, get some massage. Hey, doc, you were right. It was glute med. And they also said, hey, I've got a QL issue. I go, oh, that's interesting. So work on that QL, find out that is incredibly painful, tender to the touch. We're able to calm down the pain 50% or slightly more in the office by supporting it with the Digest Forte, that ginger, that gentian, orange peel, wormwood, a few other things in there, one other thing in there, but products. So we know there's digestive component. Then I start talking to her about it. So have you noticed anything change with your digestion over the last couple of weeks? oh, by the way, it's funny you say that kind of thing, right? And it's like, started eating salads about 3 weeks ago, really trying to lose weight, get in better shape, wants to lose 20 pounds. And oh, by the way, I was on Ozempic, took it. She couldn't remember, it was a year and a half or 2.5 years ago.
Mhm.
But took it for a while, lost some weight, then it kind of, kind of came back. But it's like, oh, that makes total sense. Shut down that. That was last week and is doing fantastic and it's, been pretty much resolved her. We've had the best week she's had, 100% better were her words. And those were the two things we did. So this is not currently taking GLP-1. This is a year and a half, maybe 2.5 years post. But I think that same mechanism of action sits there. Digestion's been compromised since then. And we were able to support that. So, going back to what can you be your signs of that? Well, I mean, Dr. V, you're the one to talk about this. We can talk about that QL or quadratus lumborum connection to digestive health in the intestines, or large intestines specifically, and how that can be an indicator of how we might be able to support and help these people.
Mm-hmm. Mm-hmm. Go ahead, Dustin.
No, he was just he just threw you a softball, man.
Yeah. So you want to share on that QL digestion connection and what we can look at as clinicians?
Yeah. So, I mean, great point. So low back pain, the quadratus lumborum muscle attaches from the iliac crest, the top of the pelvis to the bottom of the ribs. So that flank-ish low back pain, that quadratus lumborum muscle is going to spasm when the colon's not functioning so well. So that's going to be an early sign potentially that you're having some digestive issues, God forbid, the spasm of the colon, that is long-term problems. So this is an early warning sign. This is your body, we need to take advantage of what that's trying to tell us. So that quadratus lumborum spasms, colon,
the QL advantage.
QL advantage, there it is.
I can see a whole line of books. We thought of this on our podcast last week, but I could see the headache advantage, the blood pressure advantage, because it is
pain advantage is
exactly
on the horizon. Yeah, and then that glute medius, which would go along with the low back advantage. That glute medius does spaz with hormonal issues. I've had many gals that were, had IUDs or, the hormone-based IUDs or, taking the pill that's causing that glute medius to be weak, and that just sets the whole foundation crooked, right? Because then the pelvis is sitting crooked, eventually sets up scoliosis, hip pain, degeneration of that hip joint. A lot of that stuff is all hormonal related. Insulin's the mother of all hormones. It's going to affect the female hormones and male hormones. In the female, insulin causes estrogen to convert to testosterone. In the male, it causes testosterone to convert to estrogen. So the guy with hormonal problems or messing with GLPs, could potentially end up with, man boobs and crying at chick flicks. And the woman's going to end up.
They're just so good, though, Dr. V. They're just so good.
Here's how you don't cry at chick flicks. You don't watch them in the first place. Just
there you go. So yeah, I mean, doing what we can to minimize those consequences is huge in the big scheme of things. I mean, I've often said, the best thing we could have clinically would be a crystal ball. Hey, you make this change, this is what you're going to feel, look like. 10 years from now, you take this medication or you eat this broccoli. This is what you're going to eat, think, feel, look like in 10 years from now. I mean, that'd be the most powerful motivator we could have, I would think, is to really be able to truly see what's going to happen if we continue down, the road that they're following.
Mm-hmm.
Huge.
It's going to be hard to turn it around, that's for sure. When you're, if we don't do something while they're on it, when you're muscle, you've both been muscle testing people on these drugs for a long time. Have you seen any patterns arise? Anything that seems to be a repeat piece that is more damaged than anything else from a muscle testing standpoint, or is it all very individualized that you guys are finding?
Pancreatic autoimmunity.
There it is.
Right. So the autoimmune attack against the pancreas. So the flagship product for that is pancreatrophin PMG.
Pancreatrophin P. Okay.
That's one of the most common things I'm using. So I'm kind of embarrassed that I didn't bring that up in the front end of the podcast.
We got there.
Well, no, that's why thank you all for you're still listening. Right. Yeah. So you had to make it to the end. You got to earn the clinical pearls from Dr. V.
That's right.
A lot of other places, they'll put the teaser at the beginning. No, we're going to put this 35 minutes in.
Yeah, we're ready for your votes. Is this the best one? Is this so far? Are you ready to share and send this to your friends?
Right. So yeah, so pancreatrophin PMG is one of the most common things I see with that autoimmune attack. And then yes, the keeping the gut functioning, digest forte, facilitating stomach function. And again, we did say that in the front end that we need the stomach functioning well to digest
Yeah.
that protein to preserve and protect the muscle. We need. Did you hear me say need to preserve that muscle? Otherwise,
Yeah.
I mean, you end up in the Weight Watcher yo-yo craziness of
Yeah.
losing 50% of your weight is muscle, which stimulates metabolism. Then you're never going to get your metabolism back to where it was to burn the appropriate amount of calories during the day, and you're always going to have to run a calorie deficit. So do what you can to minimize those. Digest, stimulating stomach acid and keeping the pancreas healthy is, to answer your question, Dustin, the two key things I see in this for sure. Jeff?
Yeah. Yeah. No, I think that makes a lot of sense. And it made me think back to your Paraplex from Joseph Antel. Because I think, if I'm remembering right, Roy Lee, the founder of Standard Process, maybe about 60 or 80 years ago, wrote that like with an underlying digestive issue, if you have difficulty handling it, look at the pituitary, right? There's a pituitary, I think particularly stomach HCl connection there. So by looking at that, the Paraplex, which is that combination product with what I call the proteins to support the healing and repair of the pancreas, you're getting the thyroid, you're getting the adrenal, which we talked about could be stressed with that blood sugar going low. And then obviously you're getting the pancreas as well. So you're getting the protomorphogen is the technical term, but basically those healing proteins, basically, as I described to patients, those proteins support the heal and repair of those four organs, I think makes a lot of sense. It kind of marries what you guys were both talking about earlier.
Hmm. Yeah, smart tissue support is what I've landed on for myself, telling people what a protomorphogen is. It just seems to dial it in for them
Yeah.
that
Now,
way.
you just brought up a great point, Dr. Jeff, that I'm going to be checking for pituitrophin PMG on these people now. Because, I mean, imagine again the conundrum that we're talking about with pituitary. What's the other hormone the pituitary makes? Thyroid stimulating hormone, overall
Yeah.
metabolism. Whoa, here we go, right?
Yeah. Yeah.
So we need to do what we can to keep that pituitary functioning. Maybe it's going to be E manganese. That's a little bit more specific for the anterior pituitary,
Yep.
again,
Yep.
for thyroid overall metabolism. But we need to keep that metabolism working so that it doesn't, I mean, it's great business for, for the producers of these GLPs that, they're going to slow metabolism and they need them forever,
Yeah.
right? Because now their metabolism sucks and they're always, struggling with weight. So these are the things that we can do to help minimize that so that people can get the little kick, maybe get the emotional kick that they need to, get back into their skinny jeans and, that sort of stuff, and then make the dietary changes that we just talked about earlier in the soundbite, so that they can have a healthy lifestyle from there. And so yeah, there's so much in here.
Yeah, and that kind of connects up to what you were saying earlier, Dustin, where you started hypothalamus, right? Started one level up from the pituitary. So we're kind of attacking this from both ways. And I think, that's why, for those of you listening, like there is some individualization to this, right? You've heard us go through a whole bunch of products and you do great to take all of them, but probably what you need is just a couple of them, right? So working with someone to help you that understands this information, I think would be, super helpful to guide through it and maybe take a lot of awesome ideas that are here because, I can tell clinically there's some fantastic ideas here and then basically help you find that right connection to match them to what do you need to guide yourself through that process. Because there's a lot that can happen. I mean, these things, they're powerful peptides, right? It's basically what it is. They're powerful peptides. And, we see that because the weight loss is tremendous and the side effects are significant, right? Some studies up to 90%. People are having side effects. Like I said, 30% are getting off within the first few months. So they're powerful. There's a lot they can do in the body. And there's a lot you can do if you decide to take them to minimize those effects and maximize the benefit. And I think, I'm at least open to the idea that these could be effective short term for someone who really can't make those dietary changes. They just need that 1 to 3 month reset the hormones, reset the metabolism, and go that way. I still think there's better ways to do it, but I'm open to that being a positive short-term reset, break the addictions, break the cravings, and then we support them, with good quality, natural GLP-1 foods, the fiber, the protein, the healthy fats underneath it, and help them have a reset. So if you're doing it for that reason, for another reason, then I think there's a lot of ideas in this podcast that could really help out.
It sounds like a closing statement. That sounded really.
I rest my case, Your Honor.
Dr. V, do you have any last thoughts before we sign off on this one?
Yeah, I mean, again, do what you can to maintain your protein levels. Yeah, if you're in that percentage that does go down this route, do what you can. As Dr. Jeff was just talking, I thought of the line in Spider-Man of all things, with great power comes great responsibility, right? So as you're doing this using this powerful tool, do what you can to learn what caused you to get to the fluffy stage in the first place. There's another soundbite. Don't get into the fluffy stage.
Defluff with Dr. V.
But learn from what your body's trying to tell us. Take advantage of the pains, pain patterns that we try to throw some pearls in there as well. About quadratus lumborum, low back pain is a sign that you're having some digestive problems from it. To some of the fibers, the probiotics and things that we've talked about to help the colon function better, so that they don't get the blocks, intestinal blocks and so on. We're here to support you. Do your research. It's super easy to do research these days in the current market, but there's also a lot of it's biased because of the money that's behind these companies, products and companies.
And one last thing that, as you guys are talking about this, that really occurred to me is the GLP advantage, maybe, if you will, is that people are already incredibly low in the nutrients that they need to be optimally healthy in general. And when they're shutting down their diet from not wanting to eat, and they're just eating less and less, that's actually going to exacerbate these conditions that we're seeing that are due to low potassium, low magnesium, low vitamin B6, all of those other things. So this may bring a stark contrast, to bring more of those to the light, to kind of expose where they were low already. But I say all this for the practitioners out there and the people taking this is you're already probably low in nutrients, micronutrients, especially going into this. So it's going to be doubly, triply, quadruply important to make sure that you're doing something to be able to bring those in during this time, and especially after this time, to replenish and repair everything that's going on.
Yeah.
All right. That's it for today. And unless you guys have one last thing, thank you both for being here. Thanks for sharing all of this. This is being aired on the Monday before. We're all going to be meeting in Dallas on our panel discussion symposium with a few other people. So for those of you who are in the Dallas-Fort Worth area, we'll be here to answer your questions live, and that's going to be fun and exciting. Yeah.
And for those of you who aren't in the Dallas-Fort Worth area, there's airplanes and cars, so you can still come and see us. So wherever in the world you're from, come on down. We'd love to see you. We'd love to see what's going to be this weekend on Friday and Saturday.
Excellent. Thank you guys, and we'll see you guys in the next episode.